Welcome to Crazy Nurse RN Hub, where learning becomes a tradition. Come, join me as we explore the multifaceted world of nursing. Hi there, student nurses. My name is Crystal Merdocanes, clinical instructor teaching critical care nursing. For today's topic, we have the nursing management on shock, systemic inflammatory response syndrome, and multiple organ dysfunction syndrome. These conditions are serious and interrelated problems. First, let's discuss shock. It is a syndrome characterized by decreased tissue perfusion and impaired cellular metabolism. This results in an imbalance between the supply of and demand for oxygen and nutrients. The exchange of oxygen and nutrients at the cellular level is essential to life. When a cell experiences a state of hyperperfusion, the demand for oxygen and nutrients exceeds the supply at the microcirculatory level. Now let's proceed to the different classification of shock. The four main categories of shock are cardiogenic, hypovolemic, distributive, and obstructive. Although the cause, initial presentation, and management strategies vary from each type of shock, the physiologic responses of the cells to hypoperfusion are similar. Now let's discuss the cardiogenic shock. It occurs when either systolic or diastolic dysfunction of the pumping action of the heart results in reduced cardiac output. Causes of cardiogenic shock are: we have your systolic dysfunction, we also have your diastolic dysfunction, dysrhythmias, and structural factors. For the systolic dysfunction, it is the inability of the heart to pump blood forward. Examples are myocardial infarction, cardiomyopathy, blunt cardiac injury, severe systemic or pulmonary hypertension, and myocardial depression from metabolic problems. Next, we have your diastolic dysfunction. It is the inability of the heart to fill during diastole. Examples are, we have pericardial tamponade, ventricular hypertrophy, and cardiomyopathy. Next, we have dysrhythmias. It is a problem with the rate or rhythm of your heartbeat caused by changes in your heart's normal sequence of electrical impulses. Examples are bradydysrhythmias and tachydysrhythmias. Also, we have the structural factors. Examples are valvular stenosis or regurgitation, ventricular septal rupture, and tension pneumothorax. Now let's proceed to hypovolemic shock. It occurs when there is a loss of intravascular fluid volume. In hypovolemic shock, the volume is inadequate to fill the vascular space. The volume loss may either be an absolute or relative volume loss, or hypovolemia. For your absolute hypovolemia, it results when fluid is lost through hemorrhage, gastrointestinal loss such as vomiting or diarrhea, fistula drainage, diabetes insipidus, or diuresis. On the other hand, in relative hypovolemia, fluid volume moves out of the vascular space into the extravascular space, such as your interstitial or intracavitary space. This type of fluid shift is called third spacing. One example of relative volume loss is leakage of fluid from the vascular space to the interstitial space from increased capillary permeability as seen in sepsis and burns. Now let's proceed to distributive shock. It results from excessive vasodilation and the impaired distribution of blood flow. We have here different types of your distributive shock. First, we have your neurogenic shock, then anaphylactic shock, and your septic shock. For your neurogenic shock, it is a hemodynamic phenomenon that can occur within 30 minutes of a spinal injury at the 5th thoracic or T5 vertebra or above and lasts up to 6 weeks. The injury results in a massive vasodilation without compensation due to the loss of sympathetic nervous system vasoconstrictor tone. This massive vasodilation leads to a pooling of blood in the blood vessels, tissue hypoperfusion, and ultimately impaired cellular metabolism. In addition to spinal cord injury, spinal anesthesia can block transmission of impulses from the sympathetic nervous system. Depression of the vasomotor center of the medulla from drugs such as opioids and benzodiazepines can also result in decreased vasoconstrictor tone of the peripheral blood vessels, resulting in neurogenic shock. Next, we have your anaphylactic shock. It is an acute and life-threatening hypersensitivity or allergic reaction to a sensitizing substance, such as drug, chemical, vaccine, food, and insect venom. Usually, an immediate reaction causes massive vasodilation, release of vasoactive mediators, and an increase in capillary permeability. As capillary permeability increases, fluid leaks from the vascular space into the interstitial space. Next, we have your septic shock. First, let's define sepsis. It is a systemic inflammatory response to a documented or suspected infection. In as many as 10% to 30% of patients with sepsis, the causative organism is not identified. On the other hand, severe sepsis is defined as sepsis complicated by organ dysfunction, and it is diagnosed in more than 750,000 patients per year and has mortality rates as high as 28% to 50%. Septic shock, on the other hand, is the presence of sepsis with hypotension, despite fluid resuscitation along with the presence of inadequate tissue perfusion. The main organisms that cause sepsis are gram-negative and gram-positive bacteria. Parasites, fungi, and viruses can also lead to the development of sepsis and septic shock. Next, we have your obstructive shock. It develops when a physical obstruction to blood flow occurs with a decreased cardiac output. This can be caused from a restriction to diastolic filling of the right ventricle due to compression, such as your cardiac tamponade, tension pneumothorax, superior vena cava syndrome. Other causes include abdominal compartment syndrome, in which increased abdominal pressures compress the inferior vena cava, decreasing venous return to the heart. Also, we have pulmonary embolism and left ventricular thrombi cause an outflow obstruction as blood leaves the right ventricle through the pulmonary artery. This leads to decreased blood flow to the lungs as well as decreased blood return to the left atrium. Now let's proceed to the stages of shock. Shock is categorized into three clinically apparent but overlapping stages. We have the compensatory stage, the progressive stage, and the irreversible stage. In the compensatory stage, the body activates neural, hormonal, and biochemical compensatory mechanisms in an attempt to overcome the increasing consequences of anaerobic metabolism and to maintain homeostasis. The patient's clinical presentation begins to reflect the body's responses to the imbalance in oxygen supply and demand. One of the classic signs of shock is a drop in blood pressure, which occurs because of a decrease in cardiac output and a narrowing of the pulse pressure. The baroreceptors in the carotid and aortic bodies immediately respond by creating the sympathetic nervous system response. The sympathetic nervous system stimulates vasoconstriction and the release of the potent vasoconstrictors epinephrine and norepinephrine. Blood flow to the most essential or vital organs, the heart and the brain, is maintained, while blood flow to the non-vital organs such as kidneys, gastrointestinal tract, skin, and lungs is diverted or shunted. Next stage is progressive stage, which begins as compensatory mechanisms fail. Changes in the patient's mental status are important findings in this stage. The cardiovascular system is profoundly affected in the progressive stage of shock. Cardiac output begins to fall, resulting in a decrease in blood pressure and coronary artery, cerebral, and peripheral perfusion. Continued decreased cellular perfusion and resulting altered capillary permeability are the distinguishing features of this stage. Altered capillary permeability allows leakage of fluid and protein out of the vascular space into the surrounding interstitial space. In addition to the decrease in circulating volume, there is an increase in systemic interstitial edema. The patient may have anasarca or generalized edema. Fluid leakage from the vascular space also affects the solid organs such as liver, spleen, GI tract, lungs, and the peripheral tissues by further decreasing perfusion. In the final stage of shock, which is the irreversible stage, decreased perfusion from peripheral vasoconstriction and decreased cardiac output exacerbates anaerobic metabolism. The accumulation of lactic acid contributes to an increased capillary permeability and dilation of the capillaries. Increased capillary permeability allows fluid and plasma proteins to leave the vascular space and move to the interstitial space. Blood pools in the capillary beds secondary to the constricted venules and dilated arterioles. The loss of intravascular volume worsens hypotension and tachycardia and decreases coronary blood flow. Decreased coronary blood flow leads to worsening myocardial depression and a further decline in cardiac output. Cerebral blood flow cannot be maintained and cerebral ischemia results. Now let's proceed to the assessment and diagnostic studies. There is no single diagnostic study to determine whether a patient is in shock. The process of establishing a diagnosis begins with a history and physical examination. Obtaining a thorough medical and surgical history and a history of recent events such as surgery, chest pain, trauma provides valuable data. We also have diagnostic studies that include a 12-lead ECG, continuous cardiac monitoring, chest X-ray, continuous pulse oximetry, and hemodynamic monitoring, such as the arterial pressure and CVP. Now let's proceed to the nursing diagnosis. We have, first, ineffective and/or risk for ineffective perfusion. Peripheral, renal, cerebral, cardiopulmonary, gastrointestinal, and hepatic related to low blood flow or maldistribution of blood. Also, we have anxiety related to severity of condition. Now let's proceed to the planning phase of the nursing process. The overall goals in shock include evidence of adequate perfusion, restoration of normal or baseline blood pressure, return or recovery of organ function, and avoidance of complications from prolonged states of hypoperfusion. Now let's proceed to the implementation phase. First, we have the general measures. Critical factors in the successful management of a patient experiencing shock relate to the early recognition and treatment of shock state. Prompt intervention in the early stages of shock may prevent the decline to the progressive or irreversible stage. Successful management of patient in shock includes the following. First, we have the identification of patients at risk for developing shock, integration of the patient's history, physical examination, and clinical findings to establish a diagnosis, interventions to control or eliminate the cause of the decreased perfusion, protection of target and distal organs from dysfunction, and provision of multi-system supportive care. We also have here the collaborative care for patients in shock. We have your oxygenation and ventilation. Also, we have fluid resuscitation, drug therapy, and nutritional therapy. First, let's have oxygen and ventilation. Oxygen delivery is dependent on the cardiac output, available hemoglobin, and arterial oxygen saturation. Methods to optimize oxygen delivery are directed at increasing supply and decreasing demand. Supply is increased by optimizing the cardiac output with fluid replacement and drug therapy. Second is increasing the hemoglobin by the transfusion of whole blood or packed RBC, and or increasing the arterial oxygen saturation with supplemental oxygen and mechanical ventilation. You must plan care that will not disrupt the balance of oxygen supply and demand. Space activities that increase oxygen consumption, such as endotracheal suctioning and position changes appropriately for oxygen conservation. Next is fluid resuscitation. Except for cardiogenic and neurogenic shock, all other types of shock involve decreased circulating blood volume. In obstructive shock, the treatment involves alleviating or repairing the obstruction. The cornerstone of therapy for septic, hypovolemic, and anaphylactic shock is volume expansion with the administration of appropriate fluid. Before beginning fluid resuscitation, you should insert 2 large bore 14 to 16 gauge intravenous needles in order to accommodate large volume of fluid to be given to your patient. And it is preferably inserted in the antecubital veins. So here are the different fluid types that you need to administer to your patient in shock. First, we have your crystalloids. So we have the isotonic and hypertonic. For the isotonic solutions, we have your 0.9% sodium chloride or the NSS or normal saline solution. Also, we have your lactated ringers solution. These fluids primarily remain in the intravascular space, increasing intravascular volume, and it is used for initial volume replacement in most types of shock. So we have to monitor patients closely for circulatory overload. And remember, do not use lactated ringers in patients with liver failure. And lactated ringer solution may be used if hyperchloremic acidosis develops from use of NSS in fluid resuscitation. Now we'll proceed to your hypertonic solutions. We have 1.8%, 3%, 5% sodium chloride. Fluid remains in the intravascular space and it is for rapid volume expansion. It may be used for initial volume expansion in hypovolemic shock. So we have to monitor patient closely for signs of hypernatremia, such as disorientation and convulsions. Central line is preferred for infusing more than or equal to 3% sodium chloride as these solutions are caustic. Next, we have your blood or blood products, under which is packed RBC, fresh frozen plasma, and platelets. So it replaces blood loss, increases oxygen carrying capabilities of the blood, and replaces coagulation factors, as well as it helps control bleeding caused by thrombocytopenia or decreased platelets in the blood. So it is indicated for all types of shock, and precautions applied in administering any blood products. Now we have your colloids. So first we have your hetastarch or hespan. It is made from starch and acts as volume expanders. It is at least as effective as albumin, can exert osmotic effect for up to 36 hours. And it is indicated for all types of shock except cardiogenic and neurogenic. It may be 50% less costly than albumin, and it is used cautiously in patients with heart failure, renal failure, or bleeding disorders due to antiplatelet effects. Next, we have your human serum albumin 5%, plasma protein fraction 5% albumin in 500 ml NSS. It can increase plasma colloid osmotic pressure, and it is for rapid volume expansion. It is indicated to all types of shock except cardiogenic and neurogenic shock. So for our nursing implications, we have to monitor for circulatory overload. Please note that there will be mild side effects of chills, fever, urticaria, and also it is more expensive than other colloids. Lastly, we have your dextran. That includes your dextran 40 and dextran 70. These are hyperosmotic glucose polymer, and they have similar degrees of volume expansion with dextran 40 and 70, and it has longer duration of action with dextran 70. It is with limited use because of side effects including reducing platelet adhesion, diluting clotting factors. It increases the risk of bleeding, and important to monitor patient for allergic reactions and acute renal failure. Now let's proceed to drug therapy. The primary goal of drug therapy for shock is the correction of decreased tissue perfusion. Medications used to improve perfusion in shock are administered intravenously via an infusion pump and central venous line. One main reason for administering these medications via a central line is that many of them have vasoconstrictor properties that may have harmful effects if administered peripherally and the drug extravasates. So we have two types of medications that are included here. We have your sympathomimetics. These are drugs that mimic the action of the sympathetic nervous system. Also, we have your vasodilators. Patients in cardiogenic shock have decreased myocardial contractility, and vasodilators may be needed to decrease afterload. This reduces myocardial workload as well as oxygen requirements. So here are the common drugs used in shock. So we have your dobutamine, dopamine, drodrecogen alpha, epinephrine, hydrocortisone. We also have norepinephrine, phenylephrine, nitroglycerin, sodium nitroprusside, and vasopressin. Next, let's proceed to nutritional therapy. Protein-calorie malnutrition is one of the main manifestations of hypermetabolism in shock. Nutrition is vital to decreasing morbidity. Enteral nutrition should be started within the first 24 hours. Generally, parenteral nutrition is used if enteral feedings are contraindicated or fail to meet at least 80% of the patient's caloric requirements. A patient in shock should be weighed daily on the same scale at the same time of the day. If the patient experiences a significant weight loss, you should rule out dehydration before adding more calories. Large weight gains are common because of the third spacing of fluids. Therefore, daily weights serve as a better indicator of fluid status than caloric needs. Serum protein, total albumin, BUN, serum glucose, and serum electrolytes are all used to assess nutritional status. Now let's proceed to the nursing interventions. First, we have your health promotion. You have an important role in the prevention of shock. To prevent shock, you need to identify patients at risk. In general, patients who are older, those with debilitating illnesses, and those who are immunocompromised are at an increased risk. Any individual who sustains surgical or accidental trauma is at high risk for shock resulting from hemorrhage, spinal cord injury, sepsis, and other conditions. Any patient who is at risk for decreased oxygen delivery is also at risk for the development of shock. Next, we have your acute intervention. Your role in shock involves monitoring the patient's ongoing physical and emotional status. Also, you have to identify trends to detect changes in the patient's condition, planning and implementing nursing interventions and therapy, evaluating the patient's response to therapy, providing emotional support to the patient and caregivers, and collaborating with other members of the health team to coordinate care. Now let's have systemic inflammatory response syndrome and multiple organ dysfunction syndrome. First, let's have systemic inflammatory response syndrome. It is a systemic inflammatory response to a variety of insults, including infection, referred to as sepsis, ischemia, infarction, and injury. It is a generalized inflammation in organ remote from the initial insult. Many different mechanisms can trigger a systemic inflammatory response. Examples include the following. First, we have mechanical tissue trauma from burns, crush injuries, and surgical procedures. Also, we have abscess formation from intra-abdominal and extremities. Also, we have ischemic or necrotic tissue. We have your pancreatitis, vascular disease, and myocardial infarction. We also have microbial invasion from bacteria, viruses, fungi, and parasites. Also, we have endotoxin release from gram-negative and gram-positive bacteria. We also have global perfusion deficits from post-cardiac resuscitation and shock states. And lastly, regional perfusion deficits from distal perfusion deficits. Now let's have multiple organ dysfunction syndrome. It is the failure of two or more organ systems in an acutely ill patient such that homeostasis cannot be maintained without intervention. MODS results from SIRS. These two syndromes represent the ends of continuum. Transition from SIRS to MODS does not occur in a clear-cut manner. Next, we have here the clinical manifestations and management per organ system of multi-organ dysfunction syndrome. First, we have your respiratory system. So the clinical manifestations are development of ARDS. That includes severe dyspnea, partial oxygen or fraction of inspired oxygen ratio is less than 200, bilateral fluffy infiltrates on chest X-ray. We also have your pulmonary artery wedge pressure or PAWP less than 18 millimeters of mercury, ventilation and perfusion mismatch, pulmonary hypertension, increased minute ventilation, increased respiratory rate, decreased compliance, and refractory hypoxemia. For the management, we have prevention, optimizing oxygen delivery and minimizing oxygen consumption, and mechanical ventilation. That includes positive end expiratory pressure, lung protective modes, pressure control or inverse ratio ventilation or low tidal volume, permissive hypercapnia, and positioning. Example, continuous lateral rotation therapy and prone positioning. For your cardiovascular system, we have myocardial depression, massive vasodilation, decreased systemic vascular resistance or blood pressure, decreased mean arterial pressure, increased heart rate or stroke volume, increased cardiac output, systolic and diastolic dysfunction, and biventricular failure. So for the management, we have First, the volume management. Central venous or pulmonary artery catheter for hemodynamic monitoring. We also have increased preload via volume replacement and arterial pressure monitoring and maintaining the mean arterial pressure of more than 65 millimeters of mercury. We also have administration of vasopressors. And we also have intermittent or continuous oxygen saturation in venous blood or oxygen saturation in mixed venous blood monitoring. Balanced oxygen supply and demand. Also, continuous ECG monitoring and circulatory assist devices such as your intra-aortic balloon pump and ventricular assist device. Also, venous thromboembolism prophylaxis by way of administering low molecular weight or unfractionated heparin and sequential compression devices. Next, we have your central nervous system. That includes acute changes in neurologic status, fever, hepatic encephalopathy, seizures, confusion or disorientation, failure to wean or prolonged rehabilitation. So the management includes evaluating for hepatic or metabolic encephalopathy, optimizing cerebral blood flow and decreasing cerebral oxygen requirements, and preventing secondary tissue ischemia, and administering calcium channel blockers which reduce cerebral vasospasm. Next, we have your renal system. So we have here manifestations from pre-renal, the renal hypoperfusion. So the BUN or creatinine ratio is more than 20:1, decreased urine sodium of less than 20 mEq per liter, and increased urine specific gravity of more than 1.020, and increased urine osmolality or concentration. For your intrarenal, which is the acute tubular necrosis, so laboratories are, for the BUN creatinine ratio, it's less than 10:1 to 15:1. Increased urine sodium of more than 20 mEq per liter and decreased urine osmolality or the concentration of the urine and urine specific gravity of 1.010. So for the management, we have first the administration of diuretics. So we administer loop diuretics such as your furosemide, and you may need to increase dose due to decreased glomerular filtration rate. Also, we need to administer dopamine because it enhances renal blood flow, improves linear perfusion, and increases urine output if volume resuscitated, and it may work synergistically with diuretics, and of course, continuous renal replacement therapy. Also, we have your gastrointestinal system. So we have mucosal ischemia. There is decreased intramucosal pH, potential translocation of gut bacteria, and there is potential abdominal compartment syndrome. Also, there is hypoperfusion that results to decreased peristalsis, paralytic ileus, mucosal ulceration in endoscopy, and gastrointestinal bleeding. For the management, first we have your stress ulcer prophylaxis by way of administering antacids such as your Maalox, also your histamine, H2 receptor blockers, example is your famotidine. Also, we give photon pump inhibitor such as your omeprazole and also sucralfate, carafate. Also, we need to monitor abdominal distension and intra-abdominal pressures. And we have to also follow up with dietary consultation, and also we give enteral feedings. This is to stimulate mucosal activity and provide essential nutrients and optimal calories. Next, we have your hepatic system. This is manifested by bilirubin of more than 2 milligrams per deciliter or 34 micromole per liter. We also have increased liver enzymes, your ALT, AST, and GGT, increased serum ammonia, increased albumin, prealbumin, and transferrin, jaundice, and hepatic encephalopathy. So the management includes maintaining adequate tissue perfusion, providing nutritional support by way of enteral feedings, and careful use of drugs metabolized by the liver. And also we have hematologic system that includes increased bleeding times such as increased pro time and increased PTT, decreased platelet count, we call that condition as thrombocytopenia, and increased fibrin splits products, and increased the dimer test. For the management, we have to observe for bleeding from obvious and or occult sites, and also we have to replace factors being lost such as platelets, and also minimize traumatic interventions such as intramuscular injections and multiple venipunctures because this can promote bleeding. Next, we have your endocrine system. This is manifested by either hyperglycemia or hypoglycemia. The management includes continuous infusion of insulin and glucose to maintain blood glucose of less than 150 milligrams per deciliter. So now let's proceed to the nursing and collaborative management of your SIRS and MODS. The prognosis for the patient with MODS is poor, with mortality rates of 70% to 80% when 3 or more organ systems fail. The most common cause continues to be sepsis and severe sepsis. Survival improves with early, goal-directed therapy. Therefore, the most important goal is to prevent the progression of SIRS to MODS. A critical component of the nursing role is vigilant assessment and ongoing monitoring to detect early signs of deterioration or organ dysfunction. Collaborative care for patients with MODS focuses on, first, the prevention and treatment of infection. Second is maintenance of tissue oxygenation. Third is nutritional and metabolic support. And lastly, appropriate support of individual failing organs. To end this presentation, let's discuss the relationship of shock, SIRS, and MODS in a nutshell. So first, the patient has a shock. It could either be cardiogenic, hypovolemic, distributive, or obstructive, and if this shock cannot be managed well, it will progress to systemic inflammatory response syndrome. That includes mediator excess, such as the release of cytokines, oxygen-free radicals, and more. There is also widespread endothelial injury and dysfunction. There is vasodilation and increased capillary permeability, tissue edema, and neutrophil entrapment in microcirculation. And this systemic inflammatory response syndrome will lead to multiple organ dysfunction syndrome, and it targets several organs in the body. That includes your cardiovascular system, the lungs, the gastrointestinal system, liver, central nervous system, renal, and skin. So basically, these three conditions are interrelated to each other, and the multi-organ dysfunction syndrome is the end continuum of these three conditions. I believe that would be all for our discussion on the nursing management on shock, systemic inflammatory response syndrome, and multiple organ dysfunction syndrome. I hope that you learned something today. Thank you so much and have a nice day.